the Secretary of State says, health and social care is delivered by people, and I would like to pay tribute to all my former colleagues across the UK who, regardless of system, are working their best to help patients.
Hear, hear.
All 4 UK National Health Services face the same challenges of increased demand, workforce shortages and tight finances. But the NHS in England has faced almost 10 years of unprecedented austerity, with annual uplifts of about 1% for quite a significant part of the last decade. The NHS funding bill enshrines in law the government's plan to give £33 billion extra per year by 23-24. But this is a bit of a stunt, as the government doesn't have to force itself to act by law. However, I'm sure it's very welcome after such a long drought. Of course, in real terms, it represents £20 billion and is therefore not additional new money, but the extra funding already promised by the former Chancellor in 2018. While it's claimed to be the biggest uplift ever for the NHS, it amounts to a 3.4% per year, which is actually still less than the average across the history of the NHS. It should allow stabilisation of the NHS in England, but is unlikely to provide enough money for major transformation projects.
Hear, hear.
This extra funding is again to be funnelled largely into the NHS itself, to make it sound like a bigger number. But it ignores the other responsibilities of what's actually called the Department of Health and Social Care. Public health funding has been cut by £850 million, with the 10 most deprived areas in England losing over a third of their central public health funding, while the least deprived lost only 20%. Prevention services such as smoking cessation, which was mentioned earlier by a member, have been cut. This doesn't make sense, as £1 spent on helping someone to quit saves £10 in treatment of lung and heart diseases later.
Hear, hear.
Similarly, while there's an extra £1 billion for social care in the plan, the funding gap is currently estimated at £6 billion, and with up to 60% of their central budgets cut, councils simply can't make up the difference. There's little point in pouring extra money into the NHS without tackling social care. It's like trying to fill a bath without putting in the plug. While it was Labour that introduced private healthcare companies into the NHS and saddled all 4 UK health services with financially crippling private finance initiatives, PFIs, it was the coalition government's Health and Social Care Act that created the full-blown healthcare market in NHS England. The NHS long-term plan proposes to unpick some of that with legislation to remove the barriers to integration, such as by repealing Section 75, which forces commissioning groups to put contracts out to tender, and getting rid of tariffs, which can act as a perverse incentive and encourage hospital admission. It was the competitive market that drove NHS trusts in England into debts totalling £2.5 billion within 2 years. This led to the closure of beds and the downgrading and closure of A&E departments, and has caused a marked decline in emergency care services, consistently lagging about 10% behind NHS Scotland's A&E performance since March 2015. It's important to focus on the data from Type 1 emergency departments, as that's the most relevant definition. Hospital-based A&E units that are open 24 hours a day, 7 days a week. Diluting this with data from minor injuries units and walk-in centres just masks the real situation.
Hear, hear.
Performance has deteriorated in all 4 nations this winter, but while 1 in 6 patients in Scotland are waiting longer, a third of those in England and Wales are waiting more than 4 hours in A&E.
The facts.
Unlike the 3 devolved nations, NHS England does not publish the total time spent in A&E by a patient. It restarts the clock to measure trolley waits for those needing a bed. And as was mentioned by the Shadow Secretary of State, in December almost 100,000 patients waited over 4 hours and often up to 12 hours for a bed. this time is on top of the original wait in A&E. Rather than dealing with the issue, the government's plan seems to be to change the measure. But the 4-hour target is the canary in the coal mine, warning of stress on the whole system, not just in A&E, not just the flow through hospitals, but also assessing what's happening in the community. Poor disease prevention and struggling primary care services lead to more patients going to A&E, while a lack of social care provision means patients can get stuck in hospital, and that causes a lack of beds for emergencies. While the government lists social care reform in this legislative programme, the previously promised Green Paper is still nowhere to be seen, and no solution is proposed. The Scottish Government chooses to invest £276 more per head on health and social care, because in a comprehensive health system, a preemptive approach is more cost-effective. This provides significantly more GPs, nurses and beds per head of population. Free prescriptions ensure people take their medication and control chronic conditions, while joint replacements and cataract surgery, not being rationed, helps older people remain active and independent, rather than needing more and more social care. Free personal care allows the elderly to stay in their own homes, rather than ending up in care homes or even hospital. Workforce is the biggest single challenge facing health and social care services, and the problem has been aggravated by Brexit, with a 90% drop in EU nurses coming to the UK and a 1/3 increase in those leaving. As was mentioned earlier, the shortage of doctors has been acutely exacerbated by the government's changes to the annual pension tax allowance, with some doctors receiving tax bills for tens of thousands of pounds after working overtime. Many senior clinicians have been refusing to do extra shifts for which they are financially punished. This is likely to have been a major contributor to this winter's poor performance, as we haven't had a flu epidemic, and nor have we had severe weather. I wish the government and the medical bodies well in sorting out this acute problem that is only going to make life for our patients worse. 50,000 extra nurses are promised, but as only 31,500 are new staff, this will not cover the 44,000 nursing vacancies in England. And as recruitment is actually spread over 5 years, the gap is unlikely to close. I'm sure the profession, however, welcomes the government U-turn on the nursing bursary, yet another disastrous Tory policy that's having to be unpicked. However, the promise is only for £5,000 a year, compared with £10,000 in Scotland, and nursing students here will still face tuition fees. The removal of the bursary led to a 1/3 drop in nursing applications and a 5% drop in students starting each year. In contrast, 21% more nursing students are starting each year in Scotland since 2016. 6,000 extra GPs are promised to deliver 5 million extra appointments over the next 5 years. But we're still waiting for the 5,000 extra GPs that were promised in the general election in 2015. There's actually 1,000 fewer GPs in England, so I won't hold my breath. I welcome reform of the Mental Health Act, which is quite different to the legislation in Scotland, and particularly the focus on compulsory detention. But we need investment in mental health support and early intervention. It's good that we're talking much more openly about mental health issues, including of members in this place. But we are still quite some way from achieving parity of esteem. Having been on the Legislative Committee 1.5 years ago, I welcome the Healthcare Services Safety Investigation Bill. The aim is to copy the principles of air accident investigation, with a focus on learning lessons to prevent reoccurrence, rather than just apportioning blame to one person, particularly as system failure is nearly always a contributor, and the chance to design in safety is then missed. While hopefully this will improve the learning from major incidents, it would be good to see more happening to prevent them in the first place. I was working as a surgeon in 2008 when the Scottish Patient Safety Programme was set up. And the first step was a team approach to the pre-flight checks introduced in operating theatres to prevent surgical errors. As published in a review in the British Journal of Surgery, this resulted in a 37% drop in post-surgical deaths over a period of approximately 2 years, among the largest reduction in surgical deaths ever documented. I was therefore surprised to hear from one of our committee witnesses that the WHO pre-operative checklist is not standard practice across all surgical services in England. The internationally acclaimed Scottish programme now extends into every aspect of healthcare, and despite dealing with increasing numbers of older and more complex patients, has dramatically reduced hospital mortality by a quarter over the last 10 years. Reducing complications saves money as well as being better for patients. For example, a one-third drop in bed sores since 2012 is estimated to be saving £2 to £5 million a year in Scotland. The government must accept they got it wrong in 2012 with the Health and Social Care Act, and again in 2016 with the removal of the nursing bursary. They need to get rid of tuition fees, restore the bursary, and genuinely work to repair the fragmentation and damage done to the NHS in England by their market approach. The Prime Minister likes to attack the Scottish NHS, but I would gently suggest he takes the plank out of his own eye, actually reads some statistics, and focuses on sorting out the mess his party have made of the Health and Social Care Act, Health and Social Care system, for which he's actually responsible.